Good day, everyone, and welcome to today's webinar, Mitigating Survey Deficiencies, Strategies for ASC Success. Tom Terranova is CEO of Quad A, our partner webinar provider. They will also have a booth at the summit in October and would love to meet you in person. At this time, all lines are placed on mute to prevent any background noise. We will have a question and answer period, and Tom will tell you how he'd like to run that. You can type your question using the pane at the bottom of your screen. Please identify your hospital with the question, or your organization, I suppose. This webinar is being recorded and will be available at the CIHQ Partner YouTube channel within a couple of business days. There are no CEUs provided, but we'll still have an engaging conversation. It's my pleasure to turn the mic over to Tom. Sir, you have the floor.
Well, thank you very much. Thank you for having us, and thank you for attending. I see people still joining, which is great. I also want to just get some housekeeping done right away. I know that this is obviously a CIHQ event, but I'm assuming if you're here that you are already associated in some way or another with an ambulatory surgery center, whether your institution and organization are buying up ASCs, establishing ASCs, or you're just a really high achiever who wants to know everything about every provider type. We're glad to have you here. But this talk is somewhat geared towards ambulatory surgery centers, but I also want to make sure that we're responsive to all of your needs. So I'm going to ask Michelle to put up the first poll question just to get a sense of the audience here. And what I'm hoping to know is if your institution might also have group practices or kind of faculty practices that are providing surgery or procedural services, anything with an anesthesia component, not in an ASC that might be Medicare certified, but in sort of a group practice setting or private practice setting that we would consider office surgery, because the insights we're going to share today will be largely similar, but if there are areas of departure, I want to be sensitive to those. So to let you all know that we work in the ASC space and the office space, I just want to be able to answer those questions and respond to things that you might need. So I'll give a little bit for that and look at the poll question in a second, and then we'll go on to a second poll question that just helps me again provide some background. I'll just give it maybe like a minute if we've got enough answers. I don't know, Michelle, if you see the answers live, but once we have maybe even 10 or 15 answers, I'm fine closing it. It's just to get a sense. We don't need anything super scientific.
All right, sir, it looks like 75% yes.
Okay.
We do have institution 78% yes, 80% yes.
Okay, great. So I'll try to speak to anything that's specific to offices as well, if there might be a point of departure. Again, largely these are very similar. And then the second question is, if we could put the second poll up, it's essentially, what's your familiarity level with Quad A? Do you know about Quad A? I don't want to waste your time with a lot of background if you've already are very familiar with us. But I want to make sure that you know who you are and who's talking to you today. While you're answering that, just in terms of housekeeping with the Q&A, I think it's much more engaging on a webinar setting to have live questions, because if we're on a topic and you have questions, someone else might have questions, and I'd rather run out of time providing you with valuable information that you all need than saving questions for the end and potentially never answering your questions. So if we go off on a tangent, I think that's completely time well spent. So please feel free to ask your questions live in the Q&A. I have several screens here, so I can see the Q&A panel. And if I see things pop up, I will try to answer them right away. And if for some reason I miss, we can always cover it in a Q&A portion at the end. But I think it would be valuable to hear your questions as they come up. And if I'm going to answer it, I'll say we'll answer it in a couple slides. But I think it's way more responsive to you and allows us to have a much more valuable dialogue. Everyone should be able to see the poll. I saw a question. If you click polls, it did pop up differently for me the second time, or once I clicked on it, rather than when I had my screen on poll before. So it might just take clicking the little polls button at the bottom of the screen, which should have a little circle on it if you haven't read it yet. Okay, all that housekeeping being said, Michelle, you can close the second question whenever you want, and we can just get going and see where we go.
Looks like 73% have not heard of Quad A prior to today.
Perfect. Okay, we'll get through that pretty quickly. So as Michelle said, my name is Tom Terranova. I'm the CEO of Quad A. I've been the CEO since 2019, but I've been with Quad A since 2009 in a number of different capacities, starting with legislative affairs, running the accreditation organization, the accreditation arm of the whole organization. So probably 75% of our personnel falls in that program category. And then also as COO. So I've got kind of a long and wide experience with Quad A specifically. And we've been a Medicare approved ASC deeming authority since 1997. So as an organization, our experience in the ASC space is pretty robust. Our office surgery program originated in 1980. So we're 45 years of experience in the outpatient setting. We've worked with thousands of facilities around the world. Right now, we are active in 15 countries. At one point or another, we've worked in 22 countries. Our goal is to be a global accreditation organization. Most of you have said that you're not familiar with Quad A. Our history, our origin was in plastic surgery in the office. So 1977, plastic surgeons moving out of the hospital into their own private practices. As someone who was there at the time told me, it was sort of controversial and borderline malpractice at the time. So the need for an organization, a third-party impartial assessment body was critical. And so we've grown since then to be a global accreditation organization that works across specialties, across provider types. I think we have just about every ABMS specialty represented in our accredited facilities, approaching 4,000 locations around the world, obviously the lion's share in the United States. We are a nonprofit. And our motto, our goal, our mantra, our core belief is that patients are first always. So even though we work with facilities, we say our ultimate client is the patient because, and we make all of our decisions thereon. So as standards come up, as procedures come up, the first question is, how is this going to impact patient safety? And then we figure out practicality, reasonableness, rigor, price, all of those things after we make that decision, which is the go, no-go decision, which is patient safety. Our process is peer-based. We use a mix of sort of volunteer and contract surveyors who are active in the outpatient space. These are nurses and physicians who are performing surveys, and they are obviously coming into an environment that they're working in and have 20, 30 years expertise in. And the main goal is to educate. It's easy to be punitive and just kind of send you back to the drawing board and say, you're deficient, figure out how to fix it. We don't believe that that's the appropriate perspective or philosophy. Quad A is adamant that the goal is to create and provide as many high quality and safe providers as we can to the patient population. And so why would we hide the ball? The goal is to educate a facility so that they meet the bar. If they meet the bar the moment we walk through the door or, through the corrective action process, the goal is to get them to a point where they're providing the safest, most compliant, best possible care to the patient population. And so we don't see a reason to sort of slam the door in anyone's face. We want to foster partnership and collaboration to provide those resources that they need to come into compliance. I guess is our theory. I will say we have a couple differentiators with other organizations that you might be familiar with, especially if you do have an ASC. You may work with other accrediting organizations if you're not very familiar with us. There are some things that we do a little bit differently. First of all, we have a 100% compliance mandate. That means that every standard that's applicable to the facility must be compliant by the time we confer or renew accreditation. So that means there's no sort of advisory findings or you've got 80% of our keys and 90% of our standards, so you pass. If there's a single instance of a single deficiency, we hold your hand through that process. And the main reason we do that is because we know how easy it is for mid-sized organizations to kind of intend to fix something or to let a small single element, single deficiency kind of grow into a systemic thing. So what we're trying to do is set facilities that we accredit up on a strong foundation for continuous quality improvement and continuous success. So by working with you through 100% compliance, we then know, you know, and your patients can know that at some point or another, you've demonstrated full compliance, that you know you're capable of it, that you know that you can take that ball and run with it, and that it's not guesswork as to whether something has gotten corrected or not. We are highly, highly committed to specialty, to honoring specialties and the integrity of specialties. So we have what I would consider the strongest standards in the industry around specialty training and scope of specialty and making sure there's no creep. We work with facilities all the way through the correction of their deficiencies. So hand in hand with the 100% compliance mandate is that we actually stick through with the facility until we have evidence that a correction is made, rather than just an appropriate plan of correction, which is how many accrediting organizations, and I believe even the Medicare state agencies work. Once you have a plan to correct a deficiency, they say, great, and offer you your accreditation or your certification. Again, because it's really easy to come up with a plan and then get really busy and not follow through with that plan despite your best intentions. We want to be your partner all the way through completion so that we know going forward it's easier to maintain. And then the final big piece of differentiation that I always say is we have a program called PSDR, which is Patient Safety Data Reporting, which is mandatory data reporting for all operating facilities in our system. And it's all aggregate and de-identified data that goes into a huge data set that dates back to 2001. And we partner with really credible, really amazing academic institutions like Harvard, UC Davis, University College London, to produce scholarly articles that advance, one, the care of patients and safety practices, but also accreditation. So that we might use that data to improve standards, to revise them, to review interpretive guidance to make additional clarity for facilities, always with the aim towards reducing those adverse events that reveal themselves through the data. And then again, aside from standards, even just practice guidelines or guidelines that can be shared among societies on decision making and how to operate in a more safe manner, even if it doesn't go directly to accreditation. So we think that data is truly valuable and sets apart the safety in the outpatient environment in an accredited facility in a way that speaks well to regulators, insurers, and patients. Again, we've had three Medicare programs that have been approved since 97, 2011, and 2012, respectively. And we carry accreditation of our own, meaning we put ourselves through the same torture that we put facilities through in order to have our program accredited by an organization called the International Society for Quality in Healthcare. And they have an evaluation program where they look at our accreditation standards and how we do things to make sure that we're running a rigorous program. So we do all that stuff to make sure that we're at the top of our game as well. Learning objectives, we're going to try to identify common deficiencies, talk about strategies within the accreditation framework to improve compliance, engage staff, and enhance daily operations. I'll say one of my favorite phrases now. In the ASC world, compliance matters a lot on the survey. I get that, especially when you're looking for reimbursement and Medicare approval. It's really important on the day of accreditation. What's way more important than compliance on the day of accreditation is compliance on the day that you're operating on someone. I would much rather have a facility have a questionable survey than be non-compliant when someone's grandmother is on the operating table. So our goal here and our goal every day is to make sure that we're setting facilities up to live compliant operationally every day. And that's what we'll try to broach a little bit here. And then just have some corrective action processes and practices if we can identify them through these insights. The other thing I'll say is, and why I wanted questions to be live here, is that I'm going to show you the easy part, right? It's really easy for us to identify quantitatively what are most commonly cited deficiencies, what are most commonly, trends that pop up that show us areas of concern. What's really difficult is to distill the narrative findings, because every surveyor writes a really interesting narrative finding about what precisely happened at that facility. it takes a tremendous amount of time to cull through those thousands of findings, as we're doing thousands of surveys every year, to establish themes, because they're worded different, they may be cited differently. But if you ask a question, my 15 years of expertise and even the rest of our teams, if I don't know it off the top of my head or I haven't had experience with it, we can run it down. So please ask those questions, because I don't know the specifics of what you might want to hear with some of these deficiencies unless you ask it. And there, trust me, we've seen a lot. And so I'm happy to answer all those things, and I don't want to waste your time with information that you don't care about. And that's always really the valuable meat of this presentation, when we get into kind of the how people were deficient, the why they were deficient, and the what they did about it in some cases. So this is the easy part. As this thing pops up, these are kind of the broad areas. We'll go into some specifics, but these are sort of the broad areas in which deficiencies are commonly cited. You'll see a life safety code for those of you who are in or who have ASCs as well as group practices and non-Medicare deemed operating rooms, whether they're private practice or whatever. Life safety code doesn't quite apply the same way as it does in Medicare, so that would be a little area of differentiation. The other thing I'll tell you, and you'll see throughout this presentation, is since 2009, we consistently run our top 10 deficiencies reports across all of our programs. I'm sorry, each of our programs. So we run a top 10 in each of our 10 or 11 programs. Without a doubt, the most stable finding that we have is that approximately 8 out of the 10 top 10 deficiencies in each program year over year since 2019 involve documentation. Consistency of documentation, completeness of documentation, that's always the biggest thing. It's completely understandable. Physicians and nurses have trained their entire life to treat patients, not to fill out paperwork. But unfortunately, paperwork is the demonstration that we're doing the things that we say we do. And I'm sure you all have been in this as long enough to have heard at least a half a dozen nurses say at least a half a dozen times, if it's not documented, it's not done. It's a common refrain I hear. It's a common refrain from Medicare. And the documentation, unfortunately, is important. We try to limit bureaucracy, but that is the demonstration that we are following through. And you'll see that throughout these various areas. Infection control and sterilization failures happen quite frequently. And again, what you'll see is this is again, heavily dependent on documentation, sometimes a lack of awareness of even how to fill out documentation. And I will say that there was an increase in citation of infection control and sterilization practices when COVID happened, because that was obviously a prime focus of surveys. But in our experience, those citations have not fallen off. They have not become less prevalent as we've sort of renormalized after COVID. So I would encourage you, as you think about accreditation, as you just think about doing quality checks in your own organization, I pay special attention to infection control practices. Again, common areas include improper sterilization logs, and that might be one of a number of things. You may have missing dates of when loads were sterilized, who the technician was if you have multiple technicians, if you have multiple autoclaves or multiple gas sterilizers, where the load was processed. This is incredibly important, because if an indicator winds up failing, if a test winds up failing, auditing which loads came from which sterilizer are incredibly important to making sure that you re-sterilize the pieces that need to be, and maybe you don't overdo it and go back to pieces that don't need to be re-sterilized because they were in a properly functioning autoclave. Super important to kind of, for forensic purposes is the word I was looking for. And I see a question came in. I'm going to answer you in 1 second. The other piece that comes in with the logs is biological indicators. So some folks don't know how to use them. Some folks don't know how to log them. Great example I've seen of this is we had, you should have biological indicators in every load, checking to make sure that the load went to proper temperature, pressure, et cetera, for the appropriate amount of time. I know, especially in some foreign jurisdictions, they've gone to sort of mechanical indicators, and I think it's the Bowie-Dick test, and I think there's other tests that they use as well. And my understanding of those is that those test whether the cycle reached the appropriate temperature and reached the appropriate pressure. It does not indicate kind of how long it stayed at the appropriate temperature and pressure. And so there can be areas of question around, well, did the load get properly sterilized? Because we know we met the temperature and we met the pressure, but it could have been for not sufficient time. So our board believes it is very, very important to use the biological indicators, because if spores grow, spores grow. If they don't, they don't. Sort of it's a more outcome-based test. And in the logs, what we've seen before is that, there should be control tests against what's going on in your autoclave. And we've seen instances where the staff that's in charge of maintaining that log, marks that the control, that the biological indicator from the load did not create spores, nothing cultured. But they also indicated that the control didn't. Well, the control's supposed to. So either something is very wrong or the person just doesn't know how to document it, because they were saying essentially, we didn't grow bacteria in the control and we didn't grow bacteria in the one that was in the sterilizer. So, make sure, be aware of the knowledge of the staff that's in charge of this. This is an overarching anonymous question of how often do you see repeat deficiencies in the same facility? I'm not going to quantify it, one, because it would be a good educated guess, but I'll tell you too often. We see, and that's for a few reasons. One, we see backsliding, it happens to all of us. We revert to our habits. We revert to the way we're trained. Often in mid-sized to small facilities, I find that leadership is habitual instead of intentional. So things happen, a citation happens, we have a training. Okay. And then we kind of forget about that training. We kind of don't do it again. Rather than, okay, we had this issue, we were cited for it, we established a policy, we established a structure, we established a training that has repeats, it has micro-learning, it has testing for knowledge, retention to make sure that we understood it, and that there's repetition to see, to refresh. Those things that avoid backsliding, because if you've done something some way for 10 years, and then you do a corrective action, and there's one training and on a lunch on a Wednesday, that might stick for 2-3 weeks and then kind of revert back to the mean. Or the other way I think facilities revert a lot is if they have staff turnover, because if you have an extremely experienced nurse with 30 years of experience, and that nurse retires or leaves to another organization, and now you hire in a new nurse with 8 years of experience, but not 8 years of experience in that facility, you have the chance or the likelihood that 30 years of experience walking out the door was doing a heck of a lot more than was written on their job description if you're not diligently adding to it and documenting kind of new things. And so that new person walking in doesn't know that they're missing something that you expect them to do. So we see a lot of repeat deficiencies. How we manage that as an organization is that our surveyors go out with a previous report so that they know what the facility has done before. I won't speak too much to folks who kind of backslide on purpose and try to hide the ball. It happens, but I try to look at things in the most positive light and think that it's more because of habit, training just not being repetitive enough, and staff turnover, rather than folks intentionally misleading people. I will tell you our survey mechanism, we're not really going too much into this on this talk, but our survey mechanism has changed from good old-fashioned paper and pencil books to an app. And one of the features that we're building into that app will now track deficiencies so that they're kind of highlighted at a higher intensity to say this was cited the last time we surveyed, or this has been cited 3 times. You really want to check because they can seem to get the correction right, but they can't seem to maintain it. So it's an increasing level of sensitivity. And I will tell you that Medicare is also very sensitive to this. They're very sensitive to repeat deficiencies because they say kind of essentially, if we're supporting these facilities, how come they go back? And there's really no mechanism to automatically terminate somebody's Medicare contract if they have repeat deficiencies. But I can tell you if there was a legal or regulatory mechanism to do that, Medicare seems to me, I don't want to put words in their mouth, but they seem to me to have the appetite to do that. If a facility were to keep coming back, especially with condition level deficiencies that are repeated, I think if they could terminate facilities quickly on that, they would. So it is an area of emphasis. I'm looking again at this OAS and CAHPS and the reporting being done on a quarterly basis. I may be familiar with what you're talking about, but the acronyms themselves I'm not familiar with. If you can clarify what the OAS and CAHPS and reporting are done quarterly, I'm happy to answer. I'm not familiar. You may be talking about quality assurance programs and things like that. I'm not quite sure, and I want to make sure I don't answer the wrong question. So I'm going to go on, but I'll come back to that if you can add to it. Going back to sterilization, another common finding is breaks in PPE protocols and hand hygiene protocols. Surveys obviously require observation of care and clinical tracing. So as we watch people work and we read your policy, we test your actions to your policies. And so when we see breaches in hand hygiene, that's a super common one. So I think that's one to be aware of. I think you've all seen the reports that even hospitals, consistently are failing at, 30, 40, 50, 60% rate in appropriate hand hygiene. Also breaking sterile field, that kind of is fairly common. Inadequate high-level disinfection for scoping and non-autoclavable instruments is also a common finding. And I would say baked into that is inadequate dry time. What I would say to that is for sterilization, reprocessing, and everything, your staff needs to be really careful about being familiar with the manufacturer's guidance and instructions for use. That is their best friend. Even, you may not, as the leadership team, you may not be the person involved in ordering supplies, but even the person ordering supplies, if there's a sale on a product or a cleaning detergent, if there's a sale on a different brand of scope or something like that, they need to be aware that there might be differences in X brand versus Y brand of cleaning detergent, of scope, of instrument, of supply from one manufacturer to another. You may need a longer dry time. You might need a different agent. You might need a slightly different process. So being familiar and staying up on the manufacturer's guidance and the manufacturer's instructions, that has a huge impact on whether the facility is compliant or not. And those folks that are maybe buying on volume or buying for savings may not always be thinking about that. And so it's a good thing to be intentional about. Mixing of sterile and non-sterile equipment in storage is always something that we see. Corrugated boxes, shipping boxes are a huge no-no. There are infestations that can happen to that stuff through those all the time. It's a big Medicare focus and point of emphasis. Even if you're in a temperate environment, I remind people that the supply chain is global. So what might be the insects that might be living in, nesting in, and reproducing in those cardboard boxes may not come from your very temperate environment. They may come from a very exotic, lovely tropical location. So keep that in mind. Cross-contamination when cleaning and disinfecting equipment is very common. Reuse of single-use items is very common, especially with people. There's a natural tension with anybody who's got a green initiative talking about reprocessing items. There's a tension between green and sustainability initiatives and cost, obviously, and compliance from a safety perspective. Be very careful about this. If something is going to be reprocessed, make sure that it can be, that it should be, that there are instructions to reprocess and reuse. Cross-contamination, I encourage you and your team when you're doing audits or walkthroughs to take a step back and act like you're a new facility, new to the facility, and try to assess it with fresh eyes and watch your people work. It's real easy to assume things are going right because you know the process. You may have written the process. You can see how things go when they go right. But we had an investigation on a facility many years ago that just couldn't figure out where some of their infections were coming from. And they had a beautifully laid out facility, beautifully appointed, great cabinetry that kept all of their clean, sterile supplies packed away nicely. They were not overpacked, so you didn't have, forceps that were being sterilized closed and therefore, retaining foreign bodies. You didn't have overpacked drawers that were tearing the sterile supplies. But what you did have was the person in charge of sterilization storing sterile packs in the cabinet above the autoclave. And they would set the autoclave and leave and then come back and then later store the supplies. Well, the surveyor, while they were watching this happen, was standing in the room and saw the autoclaves, finish, open, vent, and all the steam just rise up directly into the cabinet with all the sterile supplies. So that insight was something that all of their mocks missed because they were kind of just assuming and following the workflow and didn't have a step back of perspective to see that they were basically, sending steam into their sterile equipment. So it was just an interesting case study in that process. Use signage, use hand washing guidelines wherever you can. Obviously, I think most facilities do stuff like this, but it's just a great reminder. Anywhere you have a process and anywhere you have a process that you might have observed weaknesses, these type of repeated micro learnings and reminders are really helpful. Obviously, from an aesthetic standpoint, you may not want your facility just plastered with reminders and processes all the time. But again, if you've done a risk assessment of your facility, you've done a quality program, and you've decided that hand hygiene, for example, is an area of risk that you're having a hard time with, put a point of emphasis on it. It's a great way to kind of clean something up. It's a great way to conduct a quality assessment and a quality improvement program that is required under Medicare. You define a question. We need to see how compliant we are with hand hygiene. You track compliance with it. You track improvement with it, and then you report back to your QAPI committee. These are low-hanging fruit that keep you compliant and improve your care and your compliance and your safety to your patients. So, assess the risk and do it. You don't have to hit everything all at once, but look for your kind of high risk, high reward non-compliance areas and address them. And this is a great way to do that. Another common issue is tears, rips, coverings and surfaces that are not cleanable. So floors with cracks in them that are not sealed, seams. This all seems kind of nitpicky, but these are sources of infections and areas of concern. Anything with infection control, I will tell you, Medicare wants an accrediting body to really question whether they should be calling condition level noncompliance. And if you're familiar with Medicare, even whether we should be calling immediate jeopardy, which means that we're going to ask you not to see patients while we remediate the problem, because essentially there's a concern that a patient is immediately at grave risk. So surfaces, tearing are really important. I don't see things like this, ripped OR bed very often or exam table very often. But one thing to consider is, are your surfaces in other areas easily cleanable? And not to say that every facility needs to do that, but if you work in an environment where there's a lot of communicable conditions, maybe cloth seating isn't the best idea. Maybe something that can be wiped down. Just again, things to take a step back and look at. More often than not, we see rips, tears, breaks in surfaces in environments that are kind of getting a little bit older. It's hard to invest in a new table. We're trying to make it last. Just be aware of that. I'll also tell you stuff like that, infection control with cuts, tears, non-cleanable surfaces. In tropical, if you happen to be in a really hot environment where you're trying to keep the sun out of the OR, One of the more novel approaches I ever saw was somebody hanging curtains in the OR because they had windows and they were trying to keep the sun from baking the room. Can't really clean those. You can't really keep them sterile. So if that's your solution, I would try to find a different solution. Not saying that's anyone out there, but I just want to share with you the kind of stuff we see. These are kind of a little bit more common things: liners, linens, exam table, paper. Again, when you're talking about disinfection, don't just look for clinical surfaces. High touch surfaces are obviously super important. Most of you have probably gone through that, or your staff has gone through that enough to know. But also the sides. I remember during COVID, we did a presentation on infection prevention in ophthalmology. And what they found was that the staff was very good at cleaning patient side of a lot of the equipment, where kind of both parties, the patient and the provider, are looking into the equipment and touching it, but weren't as diligent about cleaning the provider side. And that's still an issue for potential transmission of all kinds of infectious agents and things like that, and bacteria. So when you're talking about high touch surfaces, be aware of obviously high touch from the provider and staff side as well. And again, use the manufacturer's guidelines. Our surveyors are going to be watching you in action and checking kind of compliance with the guidelines and compliance with your own policies. Again, there's a tug between disposable use and not for sustainability purposes. I don't have an opinion. I just think they need to be done right. Your PPE needs to be really, really tight, because it's role-based, and some people obviously get in the flow of things. They're expert at something and they cut corners. I think that's an area we see a lot of deficiency, because people who do something for hundreds of times a week or a month, they get so proficient at it, they have a ton of confidence, and maybe they don't throw on the eye covers, or maybe they don't throw on the smock, and it's really important to stay diligent to that. So I would also audit that as part of one of your QAPI programs. Somebody asked, how do you recommend facilities stay updated on manufacturer's guidelines? I think this is important. It's going to depend somewhat on your staffing. If you have a purchaser, if you're kind of a large organization and you have someone whose sole job is purchasing, it's probably a little bit easier in the sense that you can give that person that task. It's probably a little harder in that person is removed from care, so may not be thinking about it the same way. But to me, I worked many, many years ago in a factory, and we had MSDS sheets for every chemical that we use, for every piece of equipment we had, every agent we use. And for those of you who don't know, MSDS is, oh no, I forget what it is. Material safety data sheet, something like that. And so those are how to be cleaned, how to be cleaned up if there's a spill, what agents counteract them. So anytime you buy something, even if it's a product that you've bought before, but made by a different manufacturer or made by a different company, right at that purchase point, I would recommend getting their data sheets, right? Getting their safety logs, getting their instructions, and then making sure that gets to the clinical team that's in charge of maintaining that. And that includes the biomeds and the clinical staff, because again, if you have two scopes that are very similar and function the same, but are made by two different manufacturers, they may require different care. But less thought of is if you buy two different HDLs that are made by two different companies, one may require 60 seconds dry time, one may require 5 minutes dry time. And if your staff is wiping down surfaces and leaving, item 2 for only a minute, it's not going to be effective. So I think the most efficient way to do it is at purchase time. But then the follow-up then has to be the communication to your staff, and then maybe sometimes audit, especially if you're using multiple manufacturers, multiple vendors. And then obviously that becomes like a management strategy point. Like, do we even want to use multiple vendors and manufacturers, or does my directive to my purchaser have to be, buy from this manufacturer, don't deviate unless we talk about it first, because someone's trying to do good for you. They're trying to save money, and then they order from somebody who's got a sale running. You just don't want to like absentmindedly walk into a buzzsaw. So I hope that answers the question. I think it's about process. And it's about process and explicit conversations with those people in those roles. It's probably a little harder for somebody who's on the care team because they're probably juggling so many more things, but they are closer to care. So they might be more aware that item one is different than item two. So it's not a canned answer, but it kind of depends a little bit. So we spent a lot of time on infection control. We'll move quicker through some of these other ones. Obviously, infection control is so big. Hopefully, it was time well spent. Personnel-related issues, this is all documents, right? Documentation in the personnel file. What I find a lot is outpatient facilities, ambulatory facilities defer to the hospital. Well, docs and nurses have to go through ACLS training at the hospital anyway. Otherwise, they wouldn't renew their privileges, or otherwise the license wouldn't be, so we know it was done. How do you know, right? How do you know? The hospital's got a huge staff. Maybe somebody is a month overdue, 2 months overdue. Do you really want that on your head? That's really, really important. How do you know that person, are you aware whether that person left the hospital or went to a different hospital, and is there a gap? You want those documents to be in your personnel files. You want job descriptions in there. You want job descriptions reviewed. Again, if you lose a nurse of 30 years, how much have they acquired sort of implicitly over their time with you? That's not spelled out in a job description. Are there annual trainings, competency assessments? What we find a lot is pretty robust onboarding training. We went through the fire drill. We went through, safe spaces. We went through how we intake patients. But what about ongoing? Often smaller facilities will miss the annual renewals, the annual reviews, annual retraining on items of importance. So be very cognizant of that. The same with screening information, vaccinations if they're required. Again, I'm going to emphasize this a few times throughout. There are the standard requirements. There are legal requirements that you have, but there's also your policy. I say that all the time to make sure that people are at least aware that they may, or if they do, overpromise and underperform. Because when we talk about drills and training, if you say, we are going to run this training monthly, you may be more ambitious than the facility up the road who says we're going to run a training quarterly. They may do 4 and you may do 10 trainings, and you may get a deficiency and they may not, because you've promised through your ambition that you're going to do this process on a monthly basis, and therefore not doing it in accordance with your policy and process becomes a problem. So, be very aware. You may want to overperform. It may be a smart choice sometimes, and maybe a good strategic choice, but, be aware of what the requirement is, document it, and then make sure you're rotating. There's a lot of good practice management tools now that set reminders. We're constantly in a battle with calendars, I know. So set those reminders. We have to update, nurse JVs, ACLS by April 3rd, nurse, AMs by December 5th. Those calendar reminders, things like that, are super helpful to keep those repetitive tasks on schedule, because that's where a lot of the fall down comes. It's either trusting third parties. Oh, they did their past training with a fire extinguisher at the institution. Or it's the repetitive nature. Like we trained you when we onboarded you, but we forgot about it the last 3 years. So that would be my high level takeaway there. These are the trainings that are super high. I'm not going to read them to you, but think again about your hazards. When we say hazard safety training or emergency safety training, we are not just talking about medical emergencies. Medicare, even states, even Quad A, is an increasing focus on what is considered all hazards risk assessment. And for those of you participating in Medicare, emergency preparedness planning, it really goes in this area. And those of you who have been in Medicare a long time know that's a relatively new chapter in the state operating manual, and it goes across all provider types. What's required there is an all hazard risk assessment. So that means, we're all very aware of fire drills, but if we're in Oklahoma, did we make an active decision of what other risks we need to have? Again, Oklahoma, do we have to talk about what we're doing in a tornado? In Florida, do we have to talk about what we're doing in a hurricane? In certain parts of the country, did we talk about, earthquake? Are you in an area that unfortunately suffers like relatively frequent civil unrest, right? That's unfortunately more and more frequent of an issue in our country and around the world. Do you have to worry about an intruder? We're not saying you have to do any of those things in particular. What any organization is going to look for is, did your governing body do a risk assessment, talk about it, think about the likelihood of certain situations? Are some of these emergencies evacuation type emergencies, and are some shelter in place type of emergencies? They require very different responses. And did you come up with a rational basis for which ones you picked, and then how you're going to handle them? And then are you drilling on it? So that training needs to be ongoing. So think about that in a holistic sense. It's really, really important. And one of our other programs, I think, is a good example. There in our rural health, which is for really rural communities, in our rural health program, there's a requirement for certain rescue drugs. And one of the rescue drugs is for like snake antivenom. Well, you don't really need that in Chicago because we don't have any venomous snakes around here. But again, the point is for the governing body to look through and say, yep, we're out in the desert in Arizona, we should have this, versus we're in Chicago, we don't really need it. So obviously not that there's a rural community in Chicago, but just you get my drift. So think that through, be deliberate with your decision making about what your training requirements are, what your risks are, and how you're going to handle them. And then again, honor your policy and your procedure. Clinical records, again, you guys train to treat, you don't really train to document. I mean, you do, but like that's not the emphasis, right? You want to treat people. Pre-op, right? Post-op, intraoperatively, keep it consistent, keep it secure, HIPAA. If you have EMR, you want to be careful that your EMR is secure, that you have an appropriate record retention, whether for the legal requirements as well as Medicare. For us, the default is 3 years, but if say your state says it's 10, then it's got to be 10. And honor your record retention policy. EMR is great. EMR can also provide a false sense of security. Whoever your creditor is with the state, audit your EMR system and how it flows according to the standards that you're working with. We have very clear checklists for what needs to be in a EMR. If those aren't required fields in your EMR, talk to your EMR provider about making them required fields. There's no reason with an EMR that anything should ever be missed that's required, but we see that it still happens. And it's usually things that we can that are like that are much more variable. I see people, it's not blood type, it's not gender, it's patient bleeding tendency, adverse drug interaction, right? Well, if they don't have them, we'll see inconsistencies. Some people will say none. Some people on staff will say NA. Some people leave it blank. Well, if you leave it blank, you leave us room to guess, and that's really difficult. And if you leave it blank consistently, that's one thing. But if half of your staff is saying NA, 25% of your staff is saying none, 10% of your staff is saying no, and then some people are just not filling it out, that is a whole world of interpretation that you don't want to have to deal with. So my sense is, even if you're using paper charts, make a policy that we say no, NA, whatever you want to say it. If you use EMR, make sure it's required and make sure that it's consistent. We see a lot. We have requirements that anesthesia concurs with the operating physician on the plan of care. That's another thing that we see inconsistently applied. You may see half of them signed off and half not. Discharge criteria, often we see, again, some percentage signed off, some percentage not. I think that's really important. Somebody asked the question, and it goes along with this: how do you handle documentation for contracted or per diem staff? I'm going to assume we're talking about the personnel records that we were just talking about, but this also goes a little bit to your integration with your other documentation, like pre and post-op. There's two ways I think it's really important to document per diem staff and potentially itinerant anesthesia if you use it. Is one, your contract with whoever you're providing, whoever your provider is, whether it's individuals or companies, list out the requirements of that document, of their file, and expect them to show up with that file. We have board members who work for itinerant anesthesia groups, and what they do, and when they show up on a facility, they have a thumb drive that has all of their people and all of their files according to what's required. Day one, when they show up, they say, here's the personnel file for the people who could potentially show up. Or your policy with them is the first, you might send me 6 anesthesia providers or 6 per diem nurses. The first day they show up, they need to have that file in hand. You can also cover to some extent with their contract, saying contracted people have to have X, Y, and Z. That's great from like a medical, legal, risk and liability standpoint. From a compliance standpoint, gosh, wouldn't you rather know that the person really does have ACLS because you put your eyes on it than trusting it's in the contract? It's a little more burdensome, but that's probably a best practice more than it is a hard and fast requirement. Contracted services lay out those requirements. You're warranting company that sends per diem nurses that you're sending people that current ACLS, current this, current that. But the best thing would be to have that USB stick, physical file, whatever it is that contains all these elements. We find that in emergency planning, in emergency drilling, and in some of this pre and post-op documentation, there is a lack of participation in facilities that use per diem nurses and itinerant anesthesia because they're not part of your organization. So the fact remains that anesthesia provider is providing care for a patient and needs to concur on the plan of care with the operating surgeon. That anesthesia needs to be integrated in the quality assurance program. That's a Medicare requirement. So even if you're using itinerant anesthesia per diem nurses, you need to find a way, whether it's if you're using a service, whether it's integrating a quality officer from them, whether they constantly send you the same provider, using that person as a representative on your quality program and your committee. You need to find a way to integrate that person or people or that institution and keep them on there. And this is a bit of a personal bugaboo. I've seen disasters, a lot of disasters, and really nice facilities that from the surface would look compliant with everything. My nightmare scenario is a surgeon or an operating physician, per diem nurse, itinerant anesthesia, and something goes wrong. Because I have experienced many facilities don't want to invest the extra time to say to the anesthesia provider, and frankly, the anesthesia provider doesn't want to do it either, show up 2 hours earlier so I can orient you to my facility, right? And nurse, show up 2 hours early so I can explain to you where to go in a fire. But I think about boarding a flight, and I know that the checklist for flights is a common analogy in healthcare nowadays. Would you get on a flight where they didn't do a pre-flight checklist? Well, then you need to do your pre-op checklist, right? And I think we can all buy into that. On the same vein, if the flight attendants didn't tell me where the exits were and go through that safety spiel, even though I've heard it 1,000 times, I'm not going to feel great about that flight. And if something goes wrong, we're not going to all the passengers are going to be way less on the same page. To me, if a flight can sit and do a 15-minute orientation or a 20-minute orientation about how to react in an emergency, a surgery center that's using, we'll just call it visiting staff to include anesthesia and nursing, should be doing that same run through. So you should have a policy for that. How do we acclimate temporary per diem staff to know where to go, where to stay, where our emergency drugs are, where the cric set is, where the AED is? Because guess what? We've had facilities where a patient arrested and the visiting physician who was working there had no idea where the equipment was to intubate the patient because it was their first day in the facility. So I think there's a documentation aspect, but even more important, there's an orientation aspect for per diem staff of any kind. I hope that answers the question. And not too scary. I hope I'm not fear-mongering, but when you've seen as many investigations as I have, it gets easy to do. I'm loving the questions. So thank you. We probably won't finish this, but I think at least I'm answering questions and not saying a bunch of stuff that you might not care about. Life safety code. We'll cover this very quickly. Life safety codes, your engineering, your fire and electrical safety. It's required by Medicare. It's probably out of your control largely. Your building people need to be involved in it. They need to read the code. They need to read the Medicare forms specifically. If you're building, if you're renovating, if you're acquiring new facilities, you need to look at the Medicare. They're called K tags. You need to know the NFPA, the National Fire Protection Agency or Association's rules that are in place, and the engineers have to look at it. We're going to send in fire safety engineers because the doctors and nurses don't know these things. The biggest thing we find here is lack of testing or documentation of testing of pickup for safety equipment and battery backups and generators, and a lack of fire separation between the surgical entity and maybe if they share a building with somebody else. And again, that's construction, so it's not an easy fix, but those are the common ones. We also do find people kind of now as technology gets more and more overbearing, we find people overloading systems that are not meant to have everything plugged in. If I told my grandfather that I needed to charge my sunglasses overnight, he'd lose his mind. He'd have lost his mind. You'll find a lot more things need to be plugged in your office than they did 40 years ago. So your electrical load might be too heavy. And signage, keeping your signage straight is always a challenge. Medication management, again, we're talking about dating, wasting. If you open a multi-use vial, the waste date may be way before the expiration date. You need a date when it was opened, when it needs to be wasted. Anything multi-use needs that is drawn in a patient carrier becomes single-use. If a surveyor finds a single-use vial open and still in the facility anywhere, that's basically an automatic immediate jeopardy, and it's a huge nightmare for you. So be very, very diligent with your inventories, with your controls over your controlled substances and in your oversight. It's huge. It is the biggest thing. Someone came back with those acronyms. Yeah, it's about the patient satisfaction surveys. That is in the reimbursement guideline. I know it's a requirement. You do have to do that. It's part of your quality assurance program, so it can serve both purposes, but satisfaction and quality are not necessarily the same thing. They're related. So the satisfaction component is part of your requirement for the reimbursement guideline. And as an accreditor, Medicare tells us to keep our nose out of the reimbursement guideline. They really firmly silo us. So I can't really even speak to that other than you have to do it to get reimbursed. It is not a component of our accreditation compliance piece because we're talking about hand hygiene, infection practices, those types of quality assurance. You can integrate them to some degree, but how happy a patient is, how cared for they feel is more of a patient experience measurement than it is a compliance measurement. So thank you for the question and for the clarification. Everyone's very familiar with lock boxes and things like that. I don't think we need to go into it. It still gets cited a lot. Classification of your drugs is really important. Emergency meds, you got to make sure they're together and that they're appropriately secured if they're controlled as well, but that they're accessible. If they're spread out in 5 different lock boxes, it's really hard to respond to an emergency. Environment and storage, again, we'll go back. We're running real short on time. But that's mainly the boxes, making sure you're not overloading things, making sure if you have, especially sterile supplies, anything that has a date on it needs to be managed as though it expires. Maybe people game the system, manufacturers put an expiration on gauze, and maybe we all don't think gauze expires. But from a survey standpoint, if they say expires in January, it needs to be out in January. Be really cognizant of that. Be cognizant of overloading things. High traffic areas, you got to move stuff out of high traffic areas, especially if it is in a sterile pack. Checking medication expiration dates. Someone's asking what surveyors expect. We expect to see the vials themselves dated appropriately, who opened them, when to waste by. We want to see inventory control logs and inventory narcotics or controlled substances logs and inventories conducted any day that they're used and weekly at a minimum. You need 2 people that are licensed to do that. And on top of that, even if you're using itinerant anesthesia, and even if they have appropriate central pharmacy that they're bringing drugs in, which is very difficult, and people do it way more than they should and not in compliance with DEA rules, even if it's being done appropriately, you need a narcotic log in the facility because you need to know what was administered to your patients when, even if the anesthesia is not there. So since we had an itinerant staff member question, I just want to put that up there. Storage challenges in limited space. I have 2 answers. My snarky one is I've seen a facility operate. We accredit a facility that is inside of an airplane and has the best sterile storage and sterilization flow I've ever seen. So I know it's possible. That's my sort of tongue-in-cheek one. It's really cool. It's really awesome. I encourage you to look at it. I encourage you to look at Orbis International and the Flying Eye Hospital because I just think it's amazing. That said, cabinetry more than space. If you can separate things by good, secure cabinetry and locking mechanisms that way, that counts as separation. You don't need a whole different room. You need a cabinet. You need things that protect your supplies from tearing and ripping. You need cleanable, sustainable kind of structures instead of piling boxes. Don't go under the sink, whatever you do. That's a breeding ground for bad things. If you got to get creative, you got to get creative. It's hard to say what those are, but locking cabinets are a great solution. A lot of people have exam rooms where there's probably more space than's needed. And back when you had files, people used to have files and paperwork in there. If you have to store stuff in there that you can use when you're turning the OR, if there's no patient in there and you can lock it accordingly, that's doable, right? So, repurposing spaces. If you're in the process of digitizing and going EMR and going digital and you used to have paper files, those old file rooms can be repurposed really well into either other exam rooms or storage for your supplies. Space is a premium, I know, in a lot of the big cities, and it's about creativity. Especially in Medicare, you don't necessarily want to do a brand new remodel because it's gonna subject you to some new requirements. I hope that answers that. I know the snark maybe didn't help, but I meant it to be equally as encouraging that it is possible. You just got to get really creative. What I want to say here to end up is that you want to have a foster of continuing readiness. As I said, it's more important that you're compliant for grandma than for me. The biggest thing I want to say about this in my closing time is audit, mock, document. Do these things yourself. Microlearn. Show how important it is to your staff through your leadership's actions. That is way more important than any deficiency, any survey, any scare tactic, right? You want to be compliant any day because we can pop in. Our surveys have to be unannounced. And you really don't want to be dealing with deficiency corrections, especially at a condition level. What I mean by all of this is any accrediting body is obligated by Medicare to survey for current non-compliance. I'm speaking very slowly and sort of like I'm talking to kindergartners on purpose, and it's not to insult you. It's because this is kind of a weird concept. We have to survey for current non-compliance. What does current non-compliance mean? Current non-compliance means we think you're still doing it. So if you run an audit in February and you say, gosh, our medical records are missing a documentation of our bleeding tendencies, we are going to document a policy change, how we're going to handle it, training. That training is going to include all of our staff. We're going to have the sign-in. We're going to have a demonstration of knowledge and have them do an exam to show that they know what the heck we're talking about, and we're documenting that change. And we come in to survey you in June. All of the records that we pull prior to you documenting all those changes, we should not be citing you for that prior non-compliance because you have taken self-correcting action. Now, if we find something after that self-correcting action, we're going to cite that. But your documentation, your diligence gets you credit, so take credit for it. If you just ignore it, or if you're not doing regular check-ins and audits and mocks and trainings and documenting where you've corrected things, we have to interpret that as being ongoing. And so those February and January medical records could subject you to deficiencies. So your diligence in sort of your mock and oversight really can save you a lot of stress. The last thing somebody said, and I know we're over, so I want to be respectful of your time, is in a Medicare ASC, can the clean and dirty room be in the same area and each area is separated by a plastic barrier? Separation can occur in a number of ways. Barriers work. You got to make sure they're complete. Time also works. It's a much more complicated maneuver to do a dirty area, bring things out of there, completely terminally clean that area, and then go to a clean space. But yeah, physical barriers, separate rooms, kind of big, wide open spaces, and time are all creative ways that you can work through compliance. I thank you for the questions. I'm sorry we didn't leave a specific question and answer time, but I'm glad we were getting live questions and able to respond to them. I hope you found this educational. I hope we can go through way more on another time if you want. I'm trying to skip a little bit ahead to the end because I believe I have a QR for you if you have questions, if you have concerns. We're always available. Our staff is always available to work with you, to answer questions if you have ASCs. And we're also, going to be at the event, as Michelle said earlier, and we're happy to answer questions there. Here's a QR to contact us for general information about accreditation, about our contact, about the application process. info@quada.org is your resource. If you have interpretation or standards questions that you want to reach out to our nurses, standards@quada.org is your resource. I will tell you, we rolled out our most recent standards very recently, and we're got a high volume of questions. Their normal goal is to reach back out to you within 2 days, 48 hours. Be a little more patient right now. I think you'll get a bounce back email asking for the same patients, but be a little more patient because they're dealing with a lot right now, and they love to do really good research and provide good information. So it may take a little longer than that just because of the volume right now. And with that, I will tell Timothy Wilson, I will work with Michelle to make sure that we get a PDF of this slide deck and circulate it to the group that was here today. And I thank you for your time and attention, and I'm happy to add anything else that you might need. Thank you.
Thanks again, Tom. Wonderful presentation. And again, if you have any questions, hit that QR code, write down those email addresses, and we will disseminate the slide deck to attendees today. I'll stay on, and Tom will stay on to take any additional questions until all the participants fall off. Thanks so much for attending.
So far, I'm only seeing thanks and no new questions. So we'll stick around until you need me to, and then we'll get you a PDF of this, Michelle.
Thank you, sir.
Michelle, it's hard for me to tell if did I successfully end the share?
Yes, sir, you did.
Okay.
I think once the number drops below 20, I'll go ahead and close it.
Perfect.
And I'll get a hold of Randy separately.
Sure.
All right. Looks like, is there one more question? No, thank you. So
and someone just asked.
Okay.
No sink in the OR. And there's a very discrete difference there. There are scoping suites that you need to have a sink in the OR. So scoping procedure rooms are different than a sterile environment. If we're surveying in a sterile operating room for surgical and there's a sink, maybe because it's pre-existing and it's an old building, that sink has to have been rendered completely inoperable. If you're in a scoping environment that needs rinsing and water, that's a different story. I hope that's helpful. And if you do any major revisions in a pre-existing building, then that sink has to come out, even if it's rendered inoperable. It's pretty strict.
Great question, Elvira.
All right. Oh, inside a separate room. That's slightly different. Please send that to standards. My gut is to say that would be fine as long as it's kind of separated out, locked, and there's a policy not for not opening it. It's sort of like going back out into the scrub area. And I've seen things like that, but I think it'd be important to verify some specifics with the nurses. But my gut reaction and knee jerk in the instances we've seen that before is that yes, in that case, yes. And that was that the sink is in the OR with a closable door for anybody who didn't read Elvira's question.
So maybe we'll wait until it drops below 10.
We're still live, yeah.
Yes, yes, sir. All right, we'll go ahead and close it off. Thanks again very
Thanks so much.
I will get you the email link or the YouTube link ASAP.
Perfect. Thank you.
Thanks. Bye, everyone.